Class. Hey guys, can you see me? Can you hear me? If so, say me hi and hello. Am I audible, visible? Okay. I hope I am. If so, let's start. Sorry for the initial glitch. I'm back here without much of a trouble. Fine. So guys, so today we are going to talk about acute inflammation. We'll be starting the new chapter of inflammation. We have done with cell injury. I think most of you must have read Robbins. I hope you must have read Robbins. And we also had a quick revision of MCQs from the first chapter of cell injury and adaptation, right? If you missed it, please go and visit all the RRR 2.0. We have done almost everything required from a CBME point of view, right? So now we are going to start about acute inflammation. I might have a little bit of gaps in the RRR 2.0 for the acute inflammation, because we will have your senior batch foray and other things going on, but definitely complete acute inflammation and henceforth most of the chapters in the Robbins, fine. So that note, let's move on to acute inflammation. So if you look at inflammation per se, right, so there are two major types of inflammation. One is acute and obviously the other one is chronic, right? Can anyone tell me what divides acute and chronic? Good evening guys. Hello Rajesh, hello Siva. So what divides acute and chronic? It's going to be the timeline, right? So something is going to happen between like few hours, right? So minutes to hours, we call it an acute inflammation. If something is going to happen for days or months, we call it a chronic inflammation. The primary thing is the duration is the major difference, right? So at the same time, we have some other differences as well. One important finding for me is hallmark. Whenever I say hallmark, remember it till you practice medicine, because it will never change, right? So hallmark of acute inflammation by default is increased vascular permeability. The permeability of the vessel increases. That's by default the hallmark of acute inflammation. And for chronic inflammation, it's TDHF. My favorite thing, the entire pathology. It's tissue destruction and healing by fibrosis. Adi, we have a separate batch of FMGE going on. This was second year MBBS students. Please ping me later on. I'll definitely help you with FMGE preparation. Fine. Okay. So TDHF stands for tissue destruction and healing by fibrosis. Okay. That's your hallmark of chronic inflammation. So wherever you have chronic inflammation, the tissue will be destroyed and the tissue will heal obviously by fibrosis. And acute inflammation generally does not heal by fibrosis or a scar tissue, right? Okay. No, Ranjana, my lectures will be on PW Med. For an UG, it will be on PW Med. Fine. Let's go to acute inflammation's hallmark, and we'll see what exactly happens in acute inflammation with a simple example, right? I'm just going to ask you a simple question. Let's make it more conversational so it's useful for you. It's like a revision as well. Can I tell a streptococcal bacterial infection as an acute? Is that statement right? Can you call it an acute? Definitely we can call it an acute, right? Streptococcal bacterial infection obviously is an acute inflammation, right? So let's assume that this green bacteria is streptococcus. The streptococcus came into the part of the skin, and we are going to understand how my neutrophil is undoubtedly the cell of acute inflammation. I'm sure you must have read from your physiology itself, right? How my neutrophil from inside a vessel is going to go outside. That's the first hurdle. Second, it's going to go to the streptococci. That's a second hurdle, and it's going to destroy and kill the streptococci, right? Because the goal of inflammation is very, very simple. You have to go and remove the offending agent, which is streptococci in this case, right? So these are the few blockers we have, and acute inflammation will take care of each and every step, how it comes outside, how it goes, and how it eats the streptococci. Once we know that, we are done with acute inflammation. That's all, as simple as that, right? Now let's assume a real life example, and we'll try to compare that with a inflammation so it's easily relatable, right? I'm sure in your home all the Diwali sweets are ready. The line by line Robbins is not required, but most all things is there in Robbins will be covered. Fine. Sure, Sandhya, I'll do it. You must have been ready, right? Now let's assume you are sitting inside your room where you're listening to a lecture, and your mom is making the Diwali sweets, and it's ready in the kitchen or in the let's say the dining table, right? So the goal is like that. You going and eating the sweet is like neutrophil eating the streptococci. For that, many things should happen. Let's assume your room door is closed. You have to stand up from your place, move to the door, and the door should be open. You have to go outside, smell the sweets, wherever it is, go search, open it, eat it, and digest it. That's what primarily acute inflammation does, right? So the neutrophil has to move outside, go to the site of infection, eat the bacteria, digest, and kill the bacteria, right? As simple as it. For our ease, we are going to divide them into two phases. One is vascular phase, which is all the changes which happens in the endothelium and blood vessel. We call it a vascular phase. And all the changes which happens with respect to a neutrophil, we call it a cellular phase, right? These are two things important. No need depth. Stick to the share, that's more than enough. Fine. So that's vascular and that's cellular phase, right? We are just going to divide them for ease of understanding. That's all. Fine. Now for ease of understanding, we'll see vascular separately, we'll see cellular separately, but inside the body both happen simultaneously and it's a single process, right? Now in say vascular phase, there are two things which happens. Let's assume you had an infection, or let's assume that someone comes and tries to hit you. What will be the first response? Will you hit them back or will you block? Obviously the first response will be you'll be blocking it. Then only you'll definitely hit back. How much ever big you are, even if you're Mike Tyson, you'll block and then only you'll punch back, right? So whenever an infection comes, the first and the immediate response is vasoconstriction. In other words, my blood vessel is trying to not let the bacteria or the virus or the fungus enter into my bloodstream. That's the first response. I'll try to block. Obviously, after I try to block, like I said, if I'm looking at the bacteria, easy to kill, I'll try to hit it back, right? The first response is vasoconstriction, and it's always a transient response. It's undoubtedly a transient response, right? That's vasoconstriction. Now, let's assume what will happen after vasoconstriction. Again, I need your help to understand few things. You must have read in physiology something called a linear flow, right? In a normal blood vessel. What do you mean by linear flow in a normal blood vessel? What do you mean by linear flow in a normal blood vessel? Where do you see the cells? In the center or in the periphery? The cells will obviously be seen in the center of a blood vessel, right? Most of the time, the cells will be in the center and the plasma will be in the periphery. That is what the linear flow means, right? In every normal blood vessel, all the cells will be in the center and the plasma will be in the periphery, right? Now, like I said, our goal is the cell has to go outside. That is our goal. So the cell is in center, it cannot go outside. So what is the first step? Should the cells remain in the center or should they come to the corner? What do you think is the first step? Obviously, it has to come to the corner, right? Perfect, right? For that, we have a process called as vasodilatation. Okay, the vessel dilates. The vessel undergoes dilatation, right? So let's assume the normal vessel is like this. Suddenly, the vessel kind of dilates like this, right? Whenever the dilatation happens, can I say there will be turbulence? You must have seen a river, stream. Whenever there's a branching, will it have turbulent blood flow? Obvious, right? Because of this vasodilatation induced, there will be turbulence of the blood flow. Whenever there's turbulence of the blood flow, can I say the heavy particles, that is cell, can come to the corner? Normally it was linear, laminar, perfect. Suddenly it becomes like this, right? So when it suddenly becomes like that, automatically all these cells of inflammation will come along the corner of the blood vessel, right? So they're going to come along the corner of the blood vessel. So we're going to name this step. In other words, I'm going to just rephrase it. All the cells of inflammation after vasodilatation goes to the corner or marginates to the corner. This process is called as an margination. Okay, it's called as a margination. Margination primary is a vascular phenomenon. It's because of the vasodilatation. And for margination, there's a molecule called as selectin. This molecule called as selectin helps in margination, right? That's a primary goal. It marginates and it's going to help in margination. As simple as that, right? Now, I have a second issue here. All the cells have come to the corner. Imagine you have gone to the room's door. Now, if the door is not open, can you go outside? You cannot go outside, right? So second step for me is, how does the endothelium give gap? The endothelium has to remove itself so that I can go outside. Otherwise, even though I marginate, I can keep hitting the blood vessel wall. I cannot go outside, right? So the next step for me is, how does the endothelium give way? Okay. So we have to understand how does the endothelium gives way or endothelium gives a gap, right? So the endothelial gaps is your increased permeability. That's the hallmark, right? There are two different ways by which endothelium gives gap. If you look at the previous edition of Robbins, we have 5 different ways. The new edition of Robbins have reduced to 2 different ways. That is more than enough for you to understand. Need not keep on reading the old unimportant things, right? So here I'm going to have two classical ways of endothelial gap formation. One, I will keep it for a very mild injury. Okay, most of the mild injury will have this. Can I say you must have, let's assume you're drinking a coffee spills, or let's assume a mosquito bites you. Can I say mosquito bite is a mild injury, provided the mosquito is normal? Definitely, right? It's a very mild injury. Do you think when a mosquito bites you today, you will feel that pain, itching till tomorrow, or maximum 10-15 minutes? Max 10-15 minutes, right? So any mild injury for me will not last for more than 10-15 minutes. The itching will be there for 10 minutes. Beyond that, you will forget, you'll go on with your life, right? So any mild injury, what happens is there's a molecule called as histamine will be released. Okay, the histamine release will cause your endothelium to contract or endothelium to retract. Either I can use the same word, it's contraction or retraction, both means one and the same. Ultimately, it's going to produce gap, right? It results in gap formation. Okay, it results in gap formation. That's what happens to the endothelium with any mild injury, whatever it may be. I gave an example of a mosquito bite. Any sort of mild injury will have the same thing, right? Then I have a little bit of moderate to severe damage. Okay, any amount of moderate to severe injury, I have two ways of destruction. What happens here is, here I'm going to have endothelial injury. The endothelium gets damaged. Okay, I'll give you an example, simple analogy. Let's assume a Hulk comes into your room. Can the Hulk break the door? Definitely. That's what endothelial damage means. The injury is so harsh, so severe, it can just break the endothelium and damage the endothelium. An example for it is burns. Can I say burns can easily damage the endothelium? Obviously, burn can burn my skin, subcutaneous tissue, entire thing, right? Burns, or you fall down, road traffic accident, your entire skin tears. Obviously, endothelium will be damaged, right? So, in any case of severe injury, there will be endothelial damage. Based on the severity, the amount of damage also differs, right? Ultimately, what happens? Be it an endothelial damage, reversible or irreversible, be it an endothelial contraction, we will have gap. Now, let's go up a little bit. Can I say now, the marginated WBC has the gate open for it to move? Is that statement right? So my cells came to the corner and the gate is open. Now the cells can easily go to the gate outside of the gate. Now I have a big issue. Though the gate is open, I am in the corner. I have to move exactly to the gate and go outside. Right? That is very, very important. If I don't know where the gate is, I'll keep on roaming all over the blood vessel. I don't know where it is, right? So for that is where cellular phase comes into play, right? Like I said, vascular and cellular phase is actually intertwined in between one place, but for understanding, we are seeing it separately, right? So let's go to cellular phase. For understanding cellular phase, I have three major rules in cellular phase, okay? So in cellular phase, we have three major things. One is called as rolling. I'll tell you why we need rolling. Second is called as adhesion. We'll also learn why do we need adhesion. Third is called as diapedesis. Diapedesis or transmigration across the endothelium wall, right? I'm just giving a random example. I hope I have an animated video of it as well. I'll show you that. Everything is on YouTube, right? So let's assume this is the place where endothelium is given gap. I hope you can see that. Okay, just a black area just for us to mark, right? Let's assume the cell is marginated here. Can I say if the gap is open there, a cell can only go here and then go outside? Because here it is sealed, it is sealed, it is sealed. All over here, the endothelium is completely sealed. I have a gap only in the black area. So it has to move till the black area for it to go outside. Yes or no? Absolutely right, right? So now, for me to move till the black area, what I have to do? I have to roll here. I have to roll on the endothelium because I've come to the corner. I don't want to go back to the center. If I go back to the center, I have a problem again. I have to come again to the corner, right? So till this, I'll roll. Then here, once I reach the area where the gap is formed, should I stop rolling? That's where I adhere, right? So once I move till the area of the gap formation, here exactly what I do, I will adhere. Adhere means just sticking there, not moving, not rolling anymore, right? Next for me is exit. That's my diapedesis, right? So it's a simple step. Imagine something is rolling and going outside, right? You have a ball, you have a gutter, it's rolling, stopping there, entering out of into the gutter. That's what is rolling, adhesion, diapedesis, going outside, right? These are three simple steps, right? I'll see if I have a video. Just give me a second. If I have a video, I'll definitely show you. I think I have. Just give me a second. It's there in the file. Okay, if the screen is visible, do let me know. Sorry for blanking the screen because I don't want you to see unwanted photos, right? Okay, let's go ahead with this. So now here you have a blood vessel where all these are interleukins. We'll talk about this more. It's moving, right? It's in the circulation. So based on the integrins level, there are few molecules which will come up here, right? We term them as selectins. All these are called as selectins. And once a selectin is there, the WBC comes and binds to it. That's the first step. And this binding is a very weak bond. So what will happen is the blood will push it. So once the blood pushes it, it will go slowly. It rolls, it rolls, it rolls. Since it's a weak bond, it rolls. On either side, it rolls, right? At some point of time, what will happen? Let's assume there's a gap. It adheres there, stops there. It adheres there, stops there, right? That's adhesion. And then it will exit. Wherever it stops, where is the gap formation? Yes, it can exit. It can exit, right? So that's what the steps are: rolling, adhesion, and classical diapedesis. Clear? And then we look at all the other steps. These are things what happens in your rolling, addition, and diapedesis, right? Now we have to learn about what are the molecules, who will activate them, who causes them, because these might come in MCQs, right? Simple process, right? So for me to roll, we saw that and WBC should bind to the endothelium. So can I say I need someone from the WBC and someone from the endothelium to bind together? Only then have an interaction, right? Be it rolling, be it addition, be it diapedesis, I need an interaction. Without that, nothing will happen, right? Now, when you look at rolling, I have two molecules, one on the endothelium, one in the WBC, right? These molecules on the endothelium is called as selectin. We have three different types of selectin. E stands for endothelial related selectin. P actually is present in both platelets and endothelium, but it's named as platelet selectin. And L stands for leukocyte, right? So it is present in WBCs. L-selectin does not play a major role in inflammation, but remember that there's a L-selectin called as an L-selectin, that's all. And WBC has a carbohydrate group called as Cellular X. Fine. So that's your Cellular X, a carbohydrate moiety, that's all. Fine. Now, when I have an endothelium like this, now tell me, just think carefully and tell me, if normally, let's assume that even a normal endothelium, I have selectin here. Is there a possibility a WBC can stick to it? If in a normal endothelium, if you have selectin, is there a possibility a WBC can stick? Definitely there is a slight possibility, right? Definitely there is a possibility WBC can definitely stick, right? Now I have a big issue here. If that can happen, when a blood vessel separates or has a branch, you will have the same turbulence, you might have the margination, might stick. It should not happen for me. I should stick only when there's an inflammation. Otherwise, I should not stick, right? So what happens is, let's assume a bacteria entered my body. Once a bacteria entered my body, my bacteria will release or make my tissue release few things called as cytokines. We'll read cytokines in the further lectures. These cytokines are the one which will activate selectins. Otherwise, in a normal person, you and me, my blood vessel wall will not have selectin in its active form. Imagine like your clotting factors. They are always inactive. I need to activate them, right? The same way, selectin needs to be activated, and those will be activated by cytokines, right? Be it a bacteria, be it a trauma, be it a burn, whatever the inflammation is, it will release interleukins, cytokines, which will activate selectin, right? Once it's activated, then my WBC can bind to it. It can slowly bind to it, and this bond between your endothelial selectin and your Cellular X, right? This is a very, very, very weak bond. If it's a weak bond, obviously the blood flow will push them out. The blood flow pushes. Since the blood flow pushes, automatically you're going to have a rolling process. It will not adhere. It will keep on rolling slowly till it finds the area or the gap where I can exit. That is very, very important for me, right? Now let's look at what happens exactly in the adhesion part, right? Adhesion also, I need molecules like this. I need molecules in the WBC. We call as integrins, beta 1 type, and I have one more thing called as beta 2 integrin, right? There are actually names for beta 1 and beta 2, not required much to remember. Just remember there are two types of integrins, beta 1 and beta 2. When you go to diseases, one of them might be absent. We'll look at them later on, right? And endothelium has something called as CAMs. CAMs stand for cell adhesion molecule. It's cell adhesion molecule, right? I have two types of CAM. I for intercellular cell adhesion molecule between two cells. V for vascular cell adhesion molecule. It's on the vessel, that's all. The same like your selectin, these CAMs will not be activated or integrins will not be activated unless and until I have inflammation. The same process, right? Let's assume this is a blood vessel. Okay, we have a huge blood vessel and the WBC kept on rolling slowly it came, and let's assume this is the place where I have the histamine induced or your damage induced gap. That's the gap, right? I can easily exit, and exactly in this place is where the change happens, right? In this place there's a change which will activate your increase in amount of interleukins. One of the important interleukin which is required here is interleukin 8. This interleukin 8 kind of activates integrin, right? So it forms a bond with my CAMs. Like I said, CAM, two types of CAM, right? One is between the cells, that's my I CAM, intercellular. One can be on the surface of a vessel, surface of an endothelium. We call it V CAM or vascular, right? It can bind, like beta 1 binds to a CAM, beta 2 binds to a CAM. Ultimately, integrin binds to the CAM, and this bond is a very strong bond, right? The bond between an integrin and a CAM is like a covalent bond. If you remember your chemistry, you do remember there are some strong bonds and some weak bonds, right? And your CAMs. And this binding will be very strong, which stops the WBC to roll. Even if the blood is flowing at a very fast pace, the WBC cannot roll. It will stop there, right? So what's the next step? With so much of difficulty, I have found the gate which is open. I have come to the gate, right? Obviously, the next step is I have to move outside, diapedesis, right? Actually, diapedesis is nothing but a transmigration across the blood vessel. It's going to migrate across the endothelium, move outside from the endothelium. Is transmigration is diapedesis, right? So I have selectin related rolling and integrin related adhesion, then transmigration. Transmigration is actually a two-step process. Most of the time, we'll read only one step, which is the molecule PCAM or CD31. P stands for platelet endothelial, same cell adhesion molecule for CAM, or CD31 is the other name for it, right? Actually, there are two steps, like I said. The first step in transmigration is WBC activation. This is very important. I'll tell you why it is important. Obviously, the second step for me is the PCAM induced exit. PCAM1 induced exit, right? Exit or transmigration, that's all. I'll tell you why this first step is very important, right? Can anyone tell me from your histology or your anatomy, the endothelium lies on a flat surface? What do we call that? You must have definitely read this. What is that surface called as? Can I say it's called as a basement membrane, right? So the endothelium here lies on a very strong surface called as the basement membrane, right? Now the only endothelium is given gap, be it with histamine or be it with damage. The basement membrane is still intact. So can a WBC go and poke the basement membrane? It cannot, right? It cannot go and poke the basement membrane, right? Because WBC is here. The only thing what my CAM can do is, CAMs are here, the PCAM is here, the PCAM is here. It will hold the WBC, squeeze the WBC and push it, right? This is what actually it can do. It can hold, change the architecture and slowly push outside. That's what my PCAM can do primarily, right? This is my PCAM. PCAM is same like my cell adhesion molecule. It will slowly exit it, right? But my concern is not that. The concern is the red line, the basement membrane. So if it is completely broken, I'm just understanding, I want your thought process, that's all. Let's assume the basement membrane is completely broken. You'll have inflammation or you'll have clot formation. What do you think will happen? If it's broken, inflammation or clot formation? Undoubtedly it will cause clot formation. You won't have inflammation, right? Because broken, right? Now I should exit at the same time, not break. Because if it breaks, it will cause a clot. If it causes a clot, nothing can go outside, right? I have two issues here. Fine. Is it fine? Is it showing good? Just give me a second. Okay, fine. Perfect. So now for me, your basement membrane is made of collagen. You know that basement membranes are made of collagen 4 only, right? So now what happens is, when the WBC activation is done, this will release non-specific collagenases. Okay, is going to release non-specific collagenases. This non-specific collagenases is nothing but is going to make the basement membrane slightly weaker. It's not going to put holes, slightly weak, so that I can squeeze and push a WBC outside, right? It is exactly non-specific. If it's a specific type 4 collagenase, it will cut the basement membrane, because basement membrane is made of collagen 4. You know that for a fact, right? It's made of collagen 4. So when you have non-specific collagenases, where do they come from? They are present in your granules of WBC. You have neutrophilic granules, eosinophilic granules. The granules have non-specific collagenases, which will be released, and that non-specific collagenases will kind of, let's say, will make it weak. It will not completely rupture it, will make it weak. So once it's weak, I can easily squeeze through it and I can easily go outside it, right? This step is very, very important. Most of the time, books don't cover this step, but without this step, a WBC cannot exit outside because basement membrane is there, fine? So now, we assume with so much of difficulty, WBC has come outside. Our goal is not here. Our goal is here. This guy streptococci is dividing at a rapid pace, because you know it produces grape-like colonies, right? Keep on dividing like that, right? And I need to go there, stop the division, eat whatever is there, right? So next step is this. I have to move here. So this step is called as chemotaxis, chemical mediated movement. Chemotaxis. Taxi came from the word taxis. Taxi is nothing but movement. It is chemical mediated movement called as chemotaxis. This movement is unidirectional, which means a cell can go to the inflammation site, it will eat and it will die. It cannot come back to the normal blood vessel. Hopefully it didn't come, because if it comes, we need to have the backflow once again, right? Just give me a second. Okay, got it. So now this happens due to a process called as an actin polymerization. We'll understand what does actin polymerization means. Before that, we need to have a simple basic information about WBCs. WBCs are epidermal derivative or mesenchymal derivative? The normal WBCs, epidermal, mesenchymal. They are mesenchymal derivative, right? So they are undoubtedly mesenchymal derivative. So when they are mesenchymal derivative, they will have molecules called as an actin and myosin, like my muscle fiber. Muscle is also mesenchyme, right? So we have two types of actin called as G-actin. You might have read this in your physiology. G stands for globular actin. And we have something called as an F-actin. F stands for filamentous actin. Okay. So G-actin are like this. Tiny globules. F-actin is like this. They are all the globular actins arranged in a line like a filament. We call it a filamentous actin. This requires ATP. So what happens in WBC is the globular actin here will form a filament. Once they form a filamentous actin, it will automatically produce a pseudopod. Okay, this is like an amoeboid or a pseudopod. It's a false arm pseudopod, right? So once it forms a pseudopod, then it breaks again. Once it breaks, it's like a movement, right? It just moves like this, right? Maybe Michael Jackson derived steps from a WBC, right? It just goes, pushes, goes, pulls, right? That's what happens. It pushes the membrane, then the entire thing pulls. Again, the filamentous actin will break down, becomes globular actin. Again, it becomes a thing, pushes here. Again, it moves. Again, it breaks down. Again, it pushes and moves here, right? That's why slowly and steadily, by actin polymerization, it has to move from G-actin to F-actin, and slowly it moves to the streptococci, right? Now it has come to the streptococci. This is where the battle starts, right? Now, how do they move it? I know it moves with actin polymerization, but who is going to tell me, okay, this is where I have streptococci? Or it can move anywhere in the body, right? I should go to a point. That is by my chemotactic mediators. We have two groups, exogenous and endogenous, right? Exogenous are something which is from the organism, from the bacteria or virus or parasite, whatever it is. Which organism causes the inflammation? That is going to give me a signal. Okay, I am here, buddy. Come and eat me if you can, right? It's a challenge. Exogenous chemotactic mediators. In your microbiology, have you heard something called a lipopolysaccharide of the bacterial covering? That's a chemotactic mediator, right? LPS, lipopolysaccharide, is a chemotactic mediator. Flagellar protein is a chemotactic mediator. Because I don't have a flagella. My body does not have a flagella. So if you have a flagellar protein, I will be 100% sure it's from a bacteria, endotoxin, everything. Because I don't produce it. If something foreign comes into my body, I know for a fact it's bacteria. Chitin, right? It's a parasite's membrane, cell wall, right? I don't have it, right? Anything which is not mine, my body will consider it foreign. Once it considers foreign, my goal of the WBC is to go and remove, right? At the same time, I have endogenous. Endogenous chemotactic mediators, the best one is complement protein C5. C5 is one of the best chemotactic mediators. I do have interleukin 8, that also is a chemotactic mediators. And we have a leukotriene called as leukotriene B4. That also is a very, very good chemotactic mediator, right? All these are produced by my body. How it's produced? When you go to inflammatory mediators, we'll read them. Once the bacteria came into my body, it will destroy my cell. This destruction will automatically produce these chemotactic mediators, the endogenous ones. And that will tell me, okay, I'm here, help me. Actually, if you remember, this was the guy who helped to activate the integrin as well, right? So that also will happen. This also will happen simultaneously, and slowly it moves to the place, right? Once it has reached the place, that's where my entire battle starts. Let's assume this is your neutrophil, and we have the nice cluster of streptococci here. Okay, it's simple. Can a neutrophil or a WBC undergo phagocytosis? They can, and they will. The first step is eating, phagocytosis, right? So now it's going to undergo phagocytosis. It's going to eat them, fine? It's going to slowly eat them. At the same time, I have in the neutrophil, I have granules, right? These are neutrophils granules. We call them an lysosomal granules. All these are nothing but enzymes there, lysosomal granules. And this thing which is being eaten, we call it an phagosome. Phago is eating, some is a collection. It's not a single bacteria. I engulf a cluster of bacteria. I have phagosome and I have lysosome. The next step is simple. We have to fuse the phagolysosome. We have fusion of phagolysosome complex. That's the next step. So once phagolysosome fuses, my WBC's enzymes are in direct contact with the bacteria. Can I say WBC enzymes can produce free radicals? They can. Can free radical kill a cell? If it can kill a cell, can it kill a bacteria? Obviously it can, right? So what is going to happen inside the phagolysosome is what is going to kill the bacteria, right? There are lots of reactions which happens inside the phagolysosome which kills the bacteria. Okay. Now I'm going to ask you a very simple question to understand why acute is so different from a chronic inflammation. Here, the killing of bacteria happens inside the, I'm writing PL for phagolysosome, which is inside the WBC, right? It's inside phagolysosome, which is inside the WBC. So now free radicals are released in a very covered or a very controlled environment. Do you think this will cause tissue damage or it won't? Will it cause tissue damage? It won't, right? That's why an acute inflammation generally will not have a tissue damage or a tissue destruction because it's very, very, very controlled. On the other hand, when you go to chronic inflammation, we will see that interleukins will be throughout. That's why it causes tissue destruction, right? So because of this, there's very, very minimal or no tissue destruction. The entire thing happens completely inside. So I don't have a tissue destruction. That's why you don't have a scar, right? But it becomes chronic, definitely you'll have a scar by default, fine? Okay, let's see how to kill the microbe. I have two ways to kill the microbe. And again, all of this happens inside the phagolysosome complex. The first way is via the neutrophil granule contents. This is a very non-specific mechanism. The neutrophilic granules has few substances called as lactoferrin. Okay, these are antibiotic like thing, right? They are like they'll try to destroy things, fine? I have few enzymes, elastase. Okay? I have phospholipases. There are few granule contents. This will kill, but not very, very effective. Right? They're not that effective. The most effective method of killing, which is we're going to read soon, is called as a respiratory burst. Respiratory burst is undoubtedly the most effective way of killing a bacteria or a parasite, whatever it is, which is the offending agent, right? This is the most effective way, and we're definitely going to read that in detail, right? The neutrophil granule content is very non-specific. There are multiple things like primary granules, secondary granules, tertiary granules. There are many enzymes which can help me to destroy it. Not much required for me, right? Let's see what happens in respiratory burst. Again, I'm reminding all this happens inside the phagolysosome, inside the WBC. Respiratory burst. So the raw material is simple, oxygen. It's based on oxygen, so we call it respiratory burst. I have an enzyme inside the phagosome called as NADPH oxidase that will oxidize oxygen and make O2 minus. This O2 minus, with the help of the enzyme SOD, we did read about SOD, right? Superoxide dismutase. So once the superoxide dismutase comes, it will be converted to H2O2, hydrogen peroxide, right? This is very, very important turning point. This has two outcomes. It has two outcomes. Based on an enzyme MPO and chloride ion, it produces something called HOCl minus. This happens primarily when the WBC is a neutrophil. Neutrophil has the maximum quantities of MPO. I'm not saying eosinophil doesn't have, basophil doesn't have, neutrophil has the maximum quantity. So as neutrophil is coming in plenty, I'll produce HOCl. On the other hand, I have something called an MBP. This is also granule content. It's a basic protein, major basic protein. Along with this, I have iodine, which produces HOI. And this will happen predominantly when the WBC is eosinophil. If you have eosinophils predominantly, I have a protein called as major basic protein that stands for MBP. That will bind with your iodine to produce HOI. Why do I two different chemicals? Are very simple. Bacteria is different, parasite is different, right? HOCl will destroy bacteria. They are very effective in destroying bacteria. 99.9%, like your Dettol advertisement. It kills 99.9% of the bacteria. It's an extremely effective bactericidal. That's why you must have learned in your physiology. Whenever you have a bacterial infection, my body will have neutrophilia. More neutrophils, because my body knows bacteria can be destroyed by neutrophils. I increase the production. And now tell me, whenever you have a parasitic infection, which WBC will elevate? Neutrophils or eosinophils or basophils or lymphocyte or monocyte? Definitely perfect. Eosinophils, right? Because this HOI is the one which is going to destroy parasites. Again, my body knows that if it's a parasite coming inside, based on the exogenous chemotactic factor, I need to send the eosinophil outside because neutrophil cannot do anything, because neutrophil can kill a bacteria efficiently. That's why it goes. If it's a parasite, I need HOI, which will destroy, which will be produced more by eosinophil. That's why different infections, I have different people coming inside to protect me, right? This is how the respiratory burst or the bacteria or the parasite will be killed, right? Now, I have one more question. Let's assume that I have the blood vessel here. Neutrophil came here, bacteria was here, and the neutrophil came, ate the bacteria and cleared it. It was a success. Do I need more WBC coming outside, or it should stop? What is your take? Do I need more and more WBC coming outside, or let it stop there? It should stop, right? More things should not come, because now if more WBC comes, I'll have tissue damage, I'll have more and more and more inflammation, right? So now neutrophil has a very, very, very specific point. It is an extremely, if you think you have deadlines, neutrophils have even stricter deadlines, right? Neutrophil has a deadline of 24 hours. In 24 hours, if it's a success, if it's able to remove entire bacteria, then it attracts a type of macrophage. This macrophage name is, let's assume it's an M2 macrophage. We'll see what is M2 when you go to chronic inflammation. This causes healing. Whatever tiny damage is done, this will try to heal it. If I'm not able to clear, I have failed in 24 hours. I'm not able to clear the bacteria in 24 hours. I should have an outcome. That time, it will attract a macrophage. This we call it an M1 macrophage, and this will convert them into chronic inflammation. Slowly, it will push them to chronic inflammation, right? The goal is very simple. I have to clear any acute inflammation within 24 hours. Healing might take some more time. That is different. But the inflammation, if it lasts more than 24 hours, my neutrophil is not able to clear the first set of bacteria which came inside. Slowly, I'm going to think of a chronic inflammatory process. I'll obviously go to the chronic inflammatory process, right? This is what happens, and this we call it an, and this success will automatically stop more WBC exit. This is with the help of a chemotactic mediators called as an interleukin 10. Interleukin 10 is anti-inflammatory. Once the inflammation is successful, it'll stop more and more WBC coming inside by doing exactly what interleukin 8 did. Maybe inactivate selectin, inactivate integrin, right? So that every WBC stays inside and will not come outside, right? That ends their entire process. Fine. Clear? Let's quickly run through it before calling it a day. So what we started was, have a WBC, I have a acute inflammation, my WBC should come outside and eat it, right? Close your eyes, put your pen down and just listen. So now I have a problem. The WBC is in the center of the stream, bloodstream. It has to come to the corner. For that I had a vasodilatation, turbulence was created, the cells went to the corner, we call it a margination, and it's a process where selectin also helps. So once margination happens, the second problem is the doors are not open. I have two ways, either I contract or retract the endothelium or I damage the endothelium based on the severity of the process, then I can have a gap formation. Once the gap is formed, the next thing is I have to go outside. I need the cellular phase for this. There happens a step called as rolling with the help of selectin and Ciallo-Lewis, a weak bond. Then whenever the door is there, it stops there, addition with the help of integrins and caps adheres there. Then diapedesis, exit, two-step process, non-specific collagenase puts some holes or some slight damage, subtle damage, then with the help of PCAM, it'll squeeze outside and go outside. Now I am outside this blood vessel, but my streptococcus is somewhere, right? So with the help of endogenous and exogenous chemotactic mediators and my actin polymerization, it slowly goes there. Once it reaches the bacteria, engulfs the bacteria, forms a phagolysosome complex, and I have non-specific killing mechanism, not good for me, the neutrophilic granules, and I have respiratory burst. With the help of oxygen, NADP oxidase, O2 minus, SOD, H2O2. With the help of chlorine, I produce HOCl to kill the bacteria. NBP and iodine, I produce HOI to kill the parasite. Once everything is done and once you are successful, it goes back and stops it by producing your anti-inflammatory cytokine, interleukin 10, which will stop everything, right? Sandeep, MPO stands for myeloperoxidase. It's hydrogen peroxide, right? It's peroxidase. That's MPNO. Fine. Okay, any other doubts? If so, let me know. Otherwise, we'll call it a day for today. Enjoy your Diwali. So see you post Diwali. All work, no play makes everyone a dull person, right? Enjoy to the fullest. Come back and definitely will read for sure, right? Okay. Thank you, Shiva. Thank you, everyone. Thank you for your time. Bye.